Good morning, and welcome to the new clerks, your first week, your first Friday of your psychiatry clerkship. For the next 30 minutes, we will review varied topics in the field through case discussion of the assigned Psyfeld episode. So, because it is your first time, just really quick, I want anyone to unmute and provide me a character, a scene, something you saw that interested you. Don't worry about providing any kind of psychiatric depth. Just to introduce a character, a scene. What did you see that you want to talk about this morning?
I can start. So I thought it was pretty interesting that to me what summed up was the closing when Jerry actually talks out. He's on stage and he's talking about how people who don't succeed at suicide, essentially, they're losers in a way. The way he frames it, I don't know if it's a function of the times or a function of I don't know if it would be acceptable nowadays or it was just it's interesting that the way he makes it says if the pills don't work, find a rope. I thought that was pretty stark to me.
Most definitely. I can't get into Larry Head's mind, but certainly that could have been a social commentary on how individuals, not only who are struggling with thoughts and perhaps even plans of suicide, but just people with mental illness in general, are made to react or suffer in silence. That said, it does briefly introduce, I think, a very important idea that I want to make sure all of us adhere to when we are seeing patients, whether it's on my service, whether it's really even beyond psychiatry itself. And that is, can this scene just remind us that every time we observe a behavior, that we always think through the biological, psychological, and sociological factors that influence that behavior. And just for a second, I want to focus on the word influence. It often comes up in case formulation, how these factors can influence the behavior. And there's an answer to that question. And it's an answer that I think provides even further information on how we should think as clinicians. That is, these varied factors can influence behavior in predisposing, precipitating, as well as perpetuating the behavior. So all of a sudden, we have a couple of ways of thinking through what we observe, whether it's during a Seinfeld episode, whether it's a film analysis, whether it's a person who comes to your clinic asking for help. We could think about it biopsychosocially. We could think about it according to what is referred to as the 3 Ps. I want you to begin to practice combining those. After you take notes, perhaps on a CL service, and you are preparing for a case presentation, inevitably you're going to get to the part where you have to formulate what you think is going on, right? That is, on your shelf exam, the thoughts you go through to provide that single best answer. In clinical practice, you'll be providing a provisional diagnosis, right? Along those lines, if you retranscribe your notes into that 3x3 rubric, where each of those factors fit, influencing your patient's chief complaint and history of present illness, you will be well prepared to begin to tell us what you think is going on when I pimp you about what you think the answer is here. Why do you think they came in today? And of course, that closely relates to treatment planning. What do you want to do to help them? All right. So along these lines, I see that stand up, and it reminds us about the social factors that implicate probably the perpetuation of individuals with, let's say, depression. That is, why don't they seek health care? Why is there a barrier to access to mental health care? And of course, there's multiple answers there. but one of which is that they just don't feel comfortable telling a person because of the stigma. And I think that stigma is a reminder, that scene is a reminder of that social factor in, of all things, perpetuating one's suffering in silence. So I agree with you. I think that was very telling. I think it was very powerful how to end this episode. And I really, at least it'll prompt a new generation of physicians, at least about 20 of you, to think through human behavior, and that includes abnormal human behavior, not only biopsychosocially, but according to those 3 Ps. What is predisposing, what is precipitating, and finally perpetuating the individual's illness? Any questions or thoughts about the stand-up in the closing credits? Any other scenes strike you that you want to talk about this morning? Interesting characters. There's no wrong answer here. Again, I don't want anyone to think that they have to attach a teaching point in psychiatry to what you observe. That's my job.
Another thing that I thought was interesting was when Elaine was at the hospital and she started seeing like visual hallucinations because she's fasting, and I guess that kind of ties into like her delirious state. But I thought that was interesting because like afterwards she also had like disorganized speech, and her thought process, I thought, kind of showed us that there was something going on psychologically maybe.
Mm-hmm. All right, so along those lines, I think one of the clinical pearls in your observation is the role visual hallucinations, or VH, play in our formulating what's going on. I think it's a nice golden rule to adhere to, that visual hallucinations should be approached as having an organic etiology until proven otherwise. Now, this is very consistent with the way that we're going to train you to think anyway. That is, irrespective of your patient's chief complaint. It doesn't matter if it's a depressed mood, an elevated, expansive, or irritable mood, right? The cardinal sign of mania, psychosis, etc. It doesn't matter. You always have to think, number one, that the behavior is normal until it's not. And even though abnormality might actually manifest seconds within their walking into the room, I still want you to train your brain to give your patient the benefit of the doubt and say that what I'm seeing is normal, even if, like a switch, you are in that second column called abnormality. That's number one. Number two, once you identify the patient's behavior as abnormal, I want you to attribute it to an underlying medical condition until proven otherwise. The last thing you could do as a clinician is reach for a mental disorder as explaining the patient's symptoms, and then have an occult, medical, or neurological condition manifest weeks to months later. Right? That's absolute negligence. So it's always due to, number one, an organic etiology, and a prime example of that is that due to an underlying medical condition. Once you have investigated and ruled that out, the next step is looking at the patient's condition, the patient's behavior, as the direct and physiologic effect of a substance. All right, again, that's another example of organic etiology. And only after that is investigated and ruled out can we begin to discuss a mental disorder playing a role in the predisposition, precipitation, and perhaps perpetuation of what you observe. Right? So I want you to adhere to that algorithm. And that brings us back to Elaine. Okay? In Elaine's case, this looks to be a behavioral manifestation of an underlying medical issue. I don't know if there's real overt evidence that Elaine is using a substance that would have induced what we're seeing. But always reframing things that it's organicity first, I'm concerned about a medical condition that either was induced by or exacerbated by her dehydration and malnutrition. And if that is true, if we get routine blood work, we look at the specific gravity of a urinalysis, they are indicative of severe dehydration. What condition are we likely to diagnose in Elaine? Anyone? Her abrupt onset of confusion that is revealed to be due to an organic etiology.
Delirium?
It is delirium. Yep. So Elaine, I think Elaine's case, her subplot is a relatively straightforward one that hallmarks delirium. A couple of quick teaching points on delirium. And looking back at one of the observations that we had made, visual hallucinations can be part of delirium. They absolutely can be. All right. So not only her confusion, but her perceptual disturbances, specifically with regard to the modality of vision, is consistent with an organic pathology. So organicity induces delirium, organicity induces visual hallucinations, and therefore organicity, some underlying medical condition, may induce visual hallucinations in the context of delirium. And it looks as if that this was at least precipitated by malnutrition and dehydration. Of course, we would want some lab work to confirm that. Quick, the definition of delirium, and we're going to talk about this more at 11 o'clock and even at 12:30 when we actually look into a couple of the films that we are going to choose to discuss in more detail later this morning. But for this particular session, I just want to review the DSM criteria for delirium, right? Usually as I stated, adhering to the 3 C's, all right? Anybody have a guess as to what the 3-part definition of delirium is, each beginning with the letter C?
Consciousness? Like an alteration in consciousness?
Number 1, right? The DSM uses a little bit of a different word. The DSM-4 used consciousness. Now we just say cognition. Consciousness being one domain. The individual must demonstrate deficits in 2 domains of cognition. Okay? Only 2. And one has to be concentration. So we'll stick with another C. We'll use the clinical term attention interchangeably here. Okay? It's a little difference between concentration and attention, but for the definition of delirium, we can interchange those 2 terms. So number 1, the first C, is that there's an alteration in cognition, that is 2 domains, one of which must be concentration/attention. All right, so somebody comes to you and they're acting like Elaine. They seem confused. They have deficits in 2 domains of cognition. What are the other 2 criteria per the DSM that we have to investigate now to diagnose delirium? Number 2 is the course, right? So abrupt onset and fluctuating. The course is defining. And I think for your shelf exam, that's very noteworthy because that single criterion, the course, abrupt onset and fluctuating, will help differentiate from dementia, currently referred to as major neurocognitive disorder. Right? So the course is defining. It must be abrupt in onset. If we interacted with Elaine 24 to 48 hours prior to her fast, she was likely to be awake, alert, and oriented. And then the final C is the cause. As I mentioned before, the cause must be organic. And once you understand that, you then understand that this condition called delirium actually is not a mental disorder, and ultimately probably will be removed from the DSM. Delirium, on the other hand, is the behavioral manifestation of an underlying physical illness with multiple potential causes, a review of which we will have later this morning. So again, cognition, course, and the cause must be due to either an underlying medical condition and or the direct and physiologic effects of a substance. Right? Both are your prime examples of organicity. That's yeah.
I'm sorry.
Huh?
So after Elaine recovers, like if she has food and she doesn't have the same symptoms, we wouldn't classify it as a disorder, right?
That's exactly right. Yep, that's exactly right. So, I mean, as a CL psychiatrist, when we are consulted for delirium, and that consult usually comes across the phone as agitation, right? In the hospital, agitation is the behavior that warrants independent clinical attention, usually resulting in a request for psychiatric consultation. And that's a CL team's job. So when we see patients who are acutely confused in the hospital, where we are investigating and we are assessing for delirium, that is exactly right. We treat the underlying cause, and then the behavioral manifestation of that underlying cause will also improve, right? And the individual, most times, will go back to their premorbid baseline, right? Now, the more severe the cause, and the older the individual, their cognition, their cognostat, if you will, might be reset at a different level, especially if their delirium is superimposed on a baseline dementia. Okay? But as per the textbook, the individual does get back to their premorbid level of functioning. That is right. And by the way, just because of professionalism, we never tell a primary team to treat the underlying cause. They get that. Our role as psychiatrists, partnering with the primary teams in the hospital, is to investigate those potential causes and then treat the behavior so that the individual is not an imminent danger to themselves or others, right? So no more pulling out catheters, no more pulling at their trach. That's a big part of treating delirium, making the patient comfortable so that their behavior does not impede essential medical care. Okay? Now, we will always offer suggestions and recommendations with regard to what lab tests to investigate, but we should never look somebody in the eye and say, just treat the underlying cause. That's pretty much understood, even before they pick up the phone and request that consult. Anything else about Elaine here? I think the other thing I want to briefly discuss pertaining to delirium is that while dehydration and/or malnutrition likely played a role in precipitating her delirium, there are also predisposing factors, and certainly two major predisposing factors, which are not necessarily seen in this episode, but you will see when you're on a consult service, include age, as I discussed before, as well as medical comorbidity. All right, so those two are independent factors. That is, anyone who is older and anyone with multiple medical comorbidities is at risk for developing delirium. So if you introduce a stressor, a precipitant, we have to pay close attention, and we have to monitor our patients closely. An easy example of that would be a surgery. That could be a major precipitant in someone who is 100 years of age with multiple medical comorbidities, right? So again, always think along the 3 Ps as well. Okay. Any other characters you want to discuss this morning? We're talking about the suicide episode of Seinfeld.
I thought George's character was interesting, partly because he has this, I don't know if it was a personality trait or whether it was a situational neuroticism, because he hears from the sidekick that something's going to happen, and he has this, now he needs to find out what's going to happen, and unfortunately he can never, which is the plot. But the fear of something's going to happen to him is now set in his mind, and I thought that was like a pretty interesting characteristic.
Yeah, so a couple of things about George Costanza. Number one, we can literally create an entire course and curriculum based on this character. And I say this because this may be the truest character that Larry David has created. George simply defies the artificial categorization of mental illness that exists in textbooks, as all human behavior does. Now, again, we do our best to look at different traits that morph into diagnostic criteria that predict likely outcomes. And that's what the DSM is. But George just doesn't fit neatly into these categories. And while, for instance, this morning, we can talk about his having perhaps an anxiety disorder, as soon as next week, we may be in a different chapter in the DSM trying to understand the behavior manifest in next week's assigned episode. And if I know it that if we continue that throughout the entire semester, the entire academic year, we could cover the entire DSM by just simply watching George Costanza through the 9 seasons of Seinfeld. Okay? That said, there are a couple things in this episode that I think prompt discussion and therefore review of aspects of mental health that are likely to appear on your shelf exam. Number one is his reaction to the clairvoyance comment. And along those lines, I think it does prompt a discussion of what is referred to as an external locus of control. So this is social learning theory, which has a low likelihood of appearing on your shelf, but there's a chance. The idea here is that individuals, generally speaking, will have some balance between internal and external locus of control. George Costanza, 99% is an external locus. His self-value, his evaluation of himself is, I would say, greater than 90% based on others' opinions of him. And therefore, he has a need to be liked. I mean, there's actually an episode, and I can't name it, where he will literally tell his best friend, yes, I need to be liked. And it's with regard to one of Jerry's current girlfriends who can't stand George. And he becomes obsessed about getting her to like him. I believe it's the masseuse. Right? That said, that just, again, brings up the issue of what is referred to as social learning theory, that internal versus external locus of control. The opposite, of course, traits that are not personified or demonstrated in George, is the individual who is told something and understands that they're the same exact person 10 minutes ago, as compared to right now, after they're told by somebody else, I think you are blank. They know that those words don't change who they are. What makes them who they are a cumulative experience over the first 20 or 30 years of their life, not others' opinions of them now. Okay? Now, when I say that, I don't mean people in your situation who wear white coats who are told by their attending that you are blank, because you have a grade dependent upon that, and that could make people anxious. So that's a specific example that we're really not referring to here. Right? We're talking outside of the context of being evaluated by a supervisor. People in general rendering opinions about who you are as a person. Okay? Internal versus external locus of control. Now, because of George's external locus, per learning theory, he is likely to be anxious. Okay? That is, there's going to be conflict between his need and what people are providing him in feedback. And that anxiety might actually manifest as an anxiety disorder. That is, his anxiety may actually become clinically significant, specifically cause clinically significant distress or impairment in functioning. And along those lines, his need, I'll use the word, obsession to understand what it is that she meant, to clarify it, certainly would allow for the diagnosis of obsessive-compulsive disorder to be high in our differential if we believe George is afflicted with clinically significant anxiety. Right? So in the 5 minutes we have left, I just want to review obsessive-compulsive disorder. Obsessive-compulsive, actually, before I get into OCD, I want to briefly pause and ask if anybody has any questions with regard to anything that I just discussed. All right. So obsessive-compulsive disorder is arguably the easiest, the most simplistic diagnosis to make in all of medicine. If you ever forget what this condition is, how this condition is defined, you actually simply look at the label. Obsessive-compulsive disorder is when an individual is afflicted with obsessions and or compulsions. You could have both, but you do not need both to rule in for the diagnosis. Right? So if an individual presents to you with obsessions, they have obsessive-compulsive disorder. If they have compulsions, they have obsessive-compulsive disorder. If, like most, and I mean 99% of mental disorders, those obsessions and or compulsions must adversely impact functioning. They must be clinically significant. There are only two syndromes in psychiatry in which that does not hold true. One is called mild neurocognitive disorder, which separates from major neurocognitive disorder, aka dementia, in that one impairs functioning and the other, mild neurocognitive disorder, does not. Right? So that's one. And the other one is hypomania. Hypomania and mania present exactly the same. Mania, clinically significant. Hypomania, by definition, is not. Other than those two conditions, every other mental disorder must result or must impair functioning in order to be called a mental disorder. But here again, the emphasis on the word disorder. Right? And OCD is no different. So the obsessions and or the compulsions must be clinically significant. And then the only other thing, which is more of a clinical pearl, is just to make sure that the individual's obsessions or their compulsions are not better explained by a larger disorder. So for instance, if their intrusive thoughts are about the danger of walking into the office because of a trauma experienced at work years ago with related symptoms including nightmares and flashbacks, their obsessive thoughts are probably not due to OCD. They're probably due to a condition called PTSD. Right? So just to make sure that the obsessions and or compulsive behaviors are not due to a larger disorder. And it's a very, and that's intuitive. I mean, if a person is telling you that they're having intrusive thoughts and you have OCD at the top of your differential and they're providing you information about avoidance behavior, about negative affirmations, about nightmares and flashbacks, I don't think any of us would rigidly say, nope, you have obsessive thoughts. Toby had told me that means OCD. We would certainly investigate those intrusive thoughts being in the context of another disorder, and there, post-traumatic stress disorder would be at the top of your list. We have 2 minutes remaining until the bottom of the hour. In closing, does anybody have any other questions or observations?
I thought the character of Gina, who was Martin's girlfriend, was really interesting because whenever, she seemed very, very eager to get Jerry's attention throughout a lot of the episode, especially right in front of her boyfriend, and she would almost get really angry if he diverted her attention and rejected her, but then at the end of the episode they moved in together and all is fine. So I thought that was really interesting.
Yeah, I mean, I think that if we begin to look at Gina's behavior, we can see that she has some issues pertaining to impulsivity and mood reactivity. Right, that her mood is highly reactive with regard to stimuli or circumstances. And when we begin looking at those aspects of behavior, we begin thinking that she may have a personality disorder to the extent that those traits or those behaviors become clinically significant. Okay? If they aren't, we'll just call it, she's got a personality. But if they're clinically significant, we can say that it looks like a personality disorder. We will then table the rest of this discussion when we talk about the personality disorders, because we'll look at some further detail with regard to understanding, number one, what goes into diagnosing a personality disorder in general, and therefore does a character like Gina portray or demonstrate those traits? And if the answer is yes, if she passes that screen, then we look at more specific details, and they morph into the actual DSM criteria of particular or specific personality disorders that we would have to run through in our differential. Any other thoughts or closing comments?
I got one. I was wondering, this might be the same thing as the beginning question about the social aspect about depression, how people don't want to come out because of everything going on. But I thought it was interesting after the episodes, they were not showing any respect to people like in a coma. They were saying how you like take stuff from them and like do all these things right in front of them also. So I just thought that was like pretty bizarre.
Yeah, and we're going to get through this, and if anybody has watched this situational comedy before, you know that this is a pervasive theme. So we will be revisiting this really every week, and I mean, no spoilers, even the finale really brings that very observation to a climax. So no doubt about that, these friends are very egocentric. That is, they have a perspective where they just simply don't have the capacity, either individually or as a group, to view a situation through anyone else's perspective but their own, right? So that's egocentrism. And because of that, we will observe behaviors where they just seem to be very disrespectful and even violate social norms with regard to what to do and what not to do in particular social situations, which of course themselves will inform the plot. In this case, the coma. All right, we'll leave it here. We're at the bottom of the hour. Red team, I will see you in about 30. We'll, I guess, officially round at 9:15. And be prepared to discuss aspects of Shakespeare's Macbeth for our Cabnormal discussion around 11 o'clock this morning, and then Night's Watch, returning to our film analysis at 12:30. All right, thank you.